Hello and welcome to Psychiatric Secrets Revealed with Dr. Mike. I'm Dr. Mike Kuna, and I'm a board-certified psychiatrist and the Associate Medical Director of Genesis Clinical Services, which is a private psychiatric and psychotherapy clinic in Wheaton, Illinois. This program is dedicated to provide you with useful information on mental health and wellness issues, and it comes to you once a month on the first Sunday of the month. Stay tuned to hear our experts, but remember that their opinion is just that, and it's not a substitute for face-to-face psychiatric or psychotherapy care. We're very pleased today to have two experts in the area of psychiatry. Ralph Orland, MD, is a board-certified psychiatrist and an associate clinical professor at Loyola University Medical School. He's received numerous teaching awards for his supervision of residents and medical students. Dr. Orland's interests include eating disorders, OCD, and general psychiatry. He's a fellow of the American Psychiatric Association as well as a board examiner. Welcome, Dr. Orland.
Glad to be here, Dr. Mike.
We also have with us Gautam Tom Sharma, MD, who completed his residency in psychiatry at Loyola University. Following his training at Loyola, Dr. Sharma completed fellowships in research and consultation psychiatry with a focus on the interface between psychiatry and medicine. He has received also numerous awards for his excellence in teaching residents and medical students at Loyola University Medical School. He's a board-certified psychiatrist, and his areas of interest include depression and anxiety disorders and adult ADD. Welcome, Dr. Sharma.
Glad to be here, Dr. Mike.
Well, today we're going to talk about something a little different, and I want to tap into not so much your expertise of psychiatry, but more of your knowledge about being a psychiatrist. And as I was telling you earlier before this show started, this is because as the two of you, I also train medical students. And the one thing that I have noticed is that fewer and fewer are showing an interest in psychiatry. And this is at a time when psychiatric disorders are becoming more and more prevalent. So I guess my first question for you, Dr. Orland, is what do you have to do to become a psychiatrist? I mean, what is the pathway that a psychiatrist follows?
So the first thing is that we go to medical school. So before going to medical school or in medical school, we often don't know what we're going to become. We're trained in many different areas and specialties. We're not just trained right from the start in mental health issues. And then at some point along the way in medical school, typically after the third year, we decide to go into a subspecialty. And for those of us who are psychiatrists, that's what we choose, and that's an additional 4 years after medical school. So first we're trained as somebody who knows about the whole body and all aspects, and we're surgeons, and we're internal medicine doctors, and we're dermatologists, and then finally we specialize in mental health.
So you're pretty much saying that you have to go, for most, the common path would be 4 years of college, followed by 4 years of medical school, followed by 4 years of residency, and then maybe even some training after that.
Right, so you're talking about many years of higher education in order to get to the position we're at.
Well, Dr. Sharma, how are psychiatrists different from other areas that people, or other disciplines that people might associate with psychiatry, like psychologists or therapists?
Sure. So, Dr. Mike, as Dr. Ralph was pointing out, we psychiatrists have gone to medical school, so that we are doctors. We are medical doctors, I should say. We are medical doctors, and that's an important part of our identity and of what we do, and it helps differentiate us from therapists. Therapists can be psychologists, they can be social workers, but those people in those individuals in those professions don't have the medical background. We are allowed to write prescriptions, so we psychiatrists are the ones who write for medications. So we manage medications. and the other professions are not able to do that.
Well, here's a question for both of you, and I think I'll start with Dr. Orland. So you're given all these choices. Obviously, you went to medical school, and if you wanted to, you could have specialized and become a surgeon or a dermatologist or an internal medicine doctor. What made you choose psychiatry above all these other different disciplines?
So that's an interesting question, and over the course of my career, I contemplate that, as I really do enjoy my work that I do. If from book learning, thinking of medical school, I would have gone into reproductive endocrinology. I would have become an OB-GYN because that was the area of book learning I liked the most. But the factor that really played a role is that I'm a terribly organized and critical thinker. And I like my freedom. I also like my creativity, which I wouldn't have been able to say when I was in medical school. I never took a psychology course in college, so here I am in psychiatry. That's interesting. I was a chemist in college. So as I got to psychiatry, one of the things I found was that I liked the freedom I was given with all the different possibilities to try to help people. It felt like a part of medicine that was the new frontier. I could be creative. And I didn't have to follow protocols because OB-GYN was protocols, and I don't like protocols. So psychiatry was sort of like I backed into it, and then once I backed into it, I find I really loved it because I was bringing order to chaos, and that made me feel good.
So here you come from a family. I know you have a medical background in your family. How did your family react when you told them you wanted to go into psychiatry as opposed to pediatrics or something?
I'm trying to remember their response. I think it was pretty neutral. My brother had a mental illness, and so they had some understanding of it. And because of that, I think that they accepted it. At that point already, they were older, they were somewhat distant, and so it was sort of a passive acceptance. But there was never a great disappointment, like, oh, we wanted you to be a surgeon or a dentist. So I think it went over quite well.
Dr. Sharma, what drove you into psychiatry?
So, Dr. Mike, I also have, contemplated this question, and for me, I can pinpoint a certain book that actually played an important role. And this book, the name of this book is called Listening to Prozac. It was by Dr. Peter Kramer. Mm-hmm. So that made a huge impression on me. I was just taken, I was taken aback, and I'm still taken aback. I'm completely, just like everybody else, we have to be mystified at the notion of how matter, the 3 pounds of matter that's in between our ears, how that produces our hopes and dreams and thoughts, fears, aspirations. It can our vision, our hearing, our how we're feeling, our attitude towards things, our personal relationships. All these very, some of them very abstract concepts, some of them certainly a very immaterial concept, like a thought, an idea. How those things are produced by matter. I mean, if we open up our brain, there's nothing but neurons. There's a lot of neurons, billions of neurons, but that's all there is. And how does that end up, why does that chain of neurons from one communicating to the other, how come it ends up with, our taste of apple pie or the color of bread that we see? None of these things can be explained by science. It is the confoundment of science. Some refer to it as the hardest problem in science, and the whole notion that we could change how a person is feeling by giving somebody molecules, that connection between mind and molecule, that is still just as amazing to me today as it was when I read that book and I decided to go into psychiatry.
So it is true. We know how hearts pump, and we know how lungs work, and we can even make an artificial kidney. These are very complex organs, but they're really simplistic when you look at the complexity of the brain. And I think I really appreciate what you're saying. It's not just the complexity of the brain. How in the world does this mass of tissue create this environment around us?
And our experiences. It's known as it's known as the hard problem of consciousness. It's a very famous phrase for people who are interested in philosophy. It's by a philosopher named David Chalmers. And so the hard problem of consciousness is the problem I'm referring to. How all these things, our experiences and everything, all these immaterial things arise from material. Another example, very simple example, is I have the intention right now of basically making my right hand into a fist. And so right now I'm doing that. How does that come about? Mm-hmm. How does my idea get translated into action? Mm-hmm. Okay, one is the action itself we can describe.
And we understand that.
We understand that. But an idea translated to that, we don't know that. We're nowhere close to knowing that. And some philosophers will go even, they're known as the Mysterians, by the way, and they will go as far as basically stating that this is a problem that we human beings may not have an answer to, ever.
It may be beyond our ability to understand.
Correct, exactly.
Now, did you think of other areas of medicine? I know you read this book and it sort of transformed what you wanted to do, but were you at one point thinking of something else?
Yes. So before I read the book, I think that helped decide my mind. But certainly before I went into before I saw what psychiatry was, as a rotating second or third year medical student, I was thinking of family medicine because I didn't exactly know what psychiatry was. I had some outdated ideas. But when I saw what psychiatry was, is that you're basically you're working closely with people and you get to find out about the person, not just about diseases. And there's this fascinating philosophical aspect to it. I think that I knew the first day of my psychiatry rotation in third year that I was going to be a psychiatrist.
Well, great. And so now here's another misconception that I'll throw to Dr. Orland, which is, do psychiatrists only prescribe medicine, or are they capable to do therapy?
So in training, psychiatrists are mandated to be competent in both. We're tested in both. We're evaluated in both. Learning about psychotherapies, demonstrating psychotherapies, as well as the psychopharmacology. The dilemma is that once individuals are out in practice, just economics and other factors make it that many psychiatrists begin to only seemingly work with medicines. And so it feels like that they really are just writing prescriptions. A good psychiatrist is constantly assessing the psychotherapeutic needs of the patient in terms of what may be needed in a session, outside of a session, how the medicines are affecting them from a psychological standpoint. So a good psychiatrist is doing a balance of both. So we're constantly doing therapy. There are definitely many of us who still provide specific psychotherapies for patients, sometimes integrated within our sessions, sometimes outside, but we're definitely capable.
And I would just like to just highlight the fact that even though you may be prescribing a medication, you are actually doing therapy within that session too, especially if you spend more than just a minute with that patient. Because you're not only assessing their mental state, you may be guiding them in some way, you may be interpreting something that they're doing, you may be highlighting a behavior or requesting them to change a behavior, and really that's what psychotherapy is. Dr. Sharma, would you say that practicing here at Genesis is different than, let's say, your typical psychiatric practice?
Well, one of the things I value most about working here at Genesis is that we get to decide how much time we spend per patient, and every patient is seen. The appointment is half an hour, and that's a big change from many other places where people are seen for 5 or 10 minutes. In that kind of a setting, that's really doesn't allow a chance to get into some of the psychotherapeutic aspects of prescribing medication. For me, there's no such thing, as you were referring to what you were saying earlier, there's no such thing as just simply prescribing medication. If you really want to do a good job, then you have to know, how does the person view their illness? How do they view taking medications? How are there likely to be obstacles here? what is their goal, what are their habits like. For example, I prescribe ADD medications for ADD, and one has to know what their typical day is like and whether they are likely to use it in a way that's not going to be helpful. For example, staying up too late or not eating at all or something like that. So all these considerations, are they important in every case? No. But are they important in many cases? Absolutely. And I don't see how 5 or 10 minutes really gets at the problem. Certainly in many situations it won't.
Well, I certainly think that sometimes going through a checklist, sometimes I know psychiatrists will just go through a list. Are you feeling suicidal? Are you tolerating the medicine? Are you taking the medicine? Those are all fine questions, but you sometimes have to get beyond that and find out what's happening. Oh, your son was just sent to prison. Could this be why you're feeling depressed right now? Or you just had a job promotion and it's very stressful. Could this be impacting your sleep? Things like that, I think you have to ask those questions, which is why it's not just a cookie-cutter sort of approach. Dr. Orlin.
And I think, since I'm involved with residency training, when residents come out, they do want to practice similar to how we practice here at Genesis. The dilemma is that many of them are forced into positions that are salaried positions from hospitals or clinics, and they're wanting the psychiatrist to do what they're able to do best or most effectively, which is to give medication. So I think a lot of them are pigeonholed into just doing their work and doing it redundantly. And I'd love to have one of them sitting here and asking why they want to become a psychiatrist, because they'd probably have a very different feel than we would have with it.
So sometimes just the economics, because psychiatrists can command a higher salary because we're doctors. It's sometimes people want to use us in the most efficient way possible, but that's not necessarily always the best way possible.
Well, medicine is a business. And I don't know if we're going to be talking about this later today or not, but medicine is run by businessmen who are looking for the best profitability for their entities and their hospitals. We as doctors are trained to take care of people, and the two aren't necessarily always on the same page. In fact, they're often not on the same page.
Now, did either of you have any sort of like a business class while you were either in medical school or in your residency?
No. I did not.
Yeah, I would say I did not either. And I think, I don't know, sometimes I think that maybe is a disadvantage, because we go into medicine because we want to treat people, but we really don't understand the business aspect of medicine, and therefore third parties come in who do understand business, but they don't necessarily understand medicine, and we get kind of stuck in between. Well, here's another question. Now, every year there are over 17,000 U.S. medical school graduates. I think the number is like 17,300 or something. In addition, there's foreign trained doctors that get residency slots in addition to those 17,000 people. So now we're up to about 20,000. And in addition to that, there are Americans who have been trained in foreign schools. I couldn't actually find the number of those that are also getting residency slots. So certainly over 20,000 doctors are graduating every year, new doctors. But somewhere under 1,000 become psychiatrists. They go into psychiatry residencies. And in fact, I know from my own experience, because I train medical students, as you folks do too, that it's really unusual to find someone who even will tell you, I have an interest in psychiatry. That's very unusual. Why do you think so few people are going into psychiatry? Dr. Sharma.
So I think maybe there's two things. One is that we as a profession obviously have not done a good enough job communicating the excitement of psychiatry. I mean, here's a profession where we get to work with people, get to help them, get to find out things about them and their story, and we do it under the rubric of the medical field. Mm-hmm. So I can't imagine anything more exciting in all of medicine. And so here, and yet we have this conundrum where not enough interest is shown by medical students. I think the other part of it is that it's the pool of applicants. People who go into medical school, I think, are going in for, they have there's a certain mentality, a certain worldview, and they go into medical to be family doctors and to be some super specialist maybe in something. And psychiatry is looked at as a soft discipline. I really do think if it was a different applicant pool, meaning if we were considering people who are interested in the humanities, the social sciences, and we look at those people who go into medical school, you'll find that their interest level is probably much greater. And I think that I think in a way we are the black sheep of medicine. I think it's actually exciting in a way. Because as I was alluding to earlier, we're dealing with the prime stuff of life. In a sense, the psychiatry is in the nexus of the medical and the material, the hard sciences and the humanities. We are at the nexus, and it's an exciting place to be. And people who have interests that are more broader than a very, very strict medical, I think they are interested.
Piggybacking off of that, and I agree with a lot of what Tom was saying, we're a cognitive-based field, so a lot of thinking. We're not procedurally based. We're not cure-based. And I think a lot of people who are brought up in the Western culture want to fix things, and many different fields of medicine fix things a lot more than we fix things. That on top of the fact that training programs basically expose students to some of the sickest psychiatric patients there are. We're talking about people with chronic psychosis. We're talking about people with addictions, really people with awful life problems. And I think they feel sort of the helplessness going in there. Not only are there students trying to learn, but on top of that, we don't have cures for these people, and there's a revolving door. And so I think they really get a negative feel about what psychiatry is. And I think if they were exposed to a different part of psychiatry where people are actually doing much better and we're helping people on a daily basis, et cetera, I think you'd have a greater pool of applicants going in.
So, back to you, Dr. Orland. So how long have you been a psychiatrist?
So I've been practicing for about 25 years. And over the course of that 25 years, my practice, what I do, really hasn't changed that much. I'm still able to choose how much time I spend with patients. I used to do more specific psychotherapy with people for a longer period of time, and basically time demands have lessened that over the course of that length of duration. But what I pride myself on is I have patients I've treated for those 25 years, and that really feels good. It's what I call the family practice model of psychiatry, because of the fact that these are people I've seen go from adolescents or young adults to middle-aged adults to even older adults, and I've seen their families, I've seen their brothers and sisters, and to me that feels really positive.
Dr. Sharma, how long have you practiced?
I've been practicing for 12 years, and I look forward to my work on most days. Like everybody else, I don't think there is such a thing as every day being absolutely fabulous. We have our challenges, we have our difficult situations, but in this profession, especially the way here at Genesis, spending time with people allows us to develop a therapeutic relationship. So it becomes a situation where that relationship is something that is really something that I value, and it's something that makes my job very enjoyable. So yeah, that's what I have to say about that.
And have you seen a change in psychiatry over those 12 years that you've been practicing?
I think that the changes that I've seen are not so much clinical. If there's any changes, they're driven by the business side of psychiatry, if you will, having to do with insurance and payment systems and things like that. But insurance has basically passed on more of their cost to people, to all of us, with higher copays and deductibles. That's a factor, because within this context, the way I view it, I Some of my patients, they are under tight financial constraints, and I look at it as my responsibility to, in a sense, look out for that. And if it becomes prohibitively expensive, that really counters my how best I can take care of them, as well as what their options are. So those are the changes I've seen. These changes, along with the recession in 2008, which we're just slowly coming out of now, in a way. So those are the big changes in my 12 years.
It certainly seems like that a lot of people have this incorrect concept of psychiatry, and it's perhaps based on a model that existed in the 60s or the 70s, sort of a psychodynamic model where the very rich would go and see an analyst, and 4 or 5 times a week they would spend an hour in free association. And I think people think of psychiatry as like being on the couch. But the reality is psychiatry is a discipline just like any other discipline that has many different aspects, from medication treatments to psychotherapeutic interventions to techniques like TMS and ECT and all sorts of other things, that it's a very different sort of a thing than it was. And a lot of the people that we see, in fact, I would say the majority of them would not be what you would consider the ultra elite people that have tremendous amounts of cash that they can spend on seeing an analyst. These are people that are trying to have families and work a job and get by, but they're suffering from an anxiety disorder, or they have depression or other things like that. Well, here's a question for you. If you had a young relative come to you and they said to you, should I go into psychiatry? What do you think? How does this look in the next 20 years? Because I'm going to be starting my career now. What would you tell them, Dr. Orland?
So I'm going to divide that. If somebody asked me if they should go into medicine, I would definitely say medicine. To be a medical doctor or an osteopathic doctor, it's a profession. It feels really as a positive thing. It's an identity, and I really think for me it's been terribly fulfilling, and I think it's for anybody who joins that elite group. Psychiatry, you'd have to really talk to that person and say, what are you really interested in? As Tom was saying earlier, if you're fascinated by consciousness in the brain and actions, etc., that would be a good reason to go into our field, because there'll still be some element of that. If you're interested in doing procedures, it's a little more questionable. We may have things down the road that make us much more of a procedural-based occupation. If you don't have frustration tolerance, you probably shouldn't be in this field. So I would really have to sit with that person and say, well, what are you really feeling you want to do? Because psychiatry is not for everybody.
Tom?
Just to that, I would like to add, yes, I think frustration tolerance and patience, I think, is important. I'm sure it's important in every profession, but certainly in this one. And I would also like to add that our outcomes in psychiatry may be better than what people think. So most a lot of psychiatric conditions, certainly a lot of the more serious ones, do tend to be chronic and or recurrent. However, we do get results. It's a trial and error process sometimes, but with medications, with psychotherapy, with lifestyle adjustments, sometimes with getting the family involved, sometimes with group treatment, sometimes with procedures, more rarely. But with different things, we are able to get results. Certainly the vast majority of the patients who see me are doing better by the second or third or fourth or fifth visit. And I don't think I'm any special in that way. I think that would hold true for most psychiatrists. I certainly hope it does.
Yeah, I would say, too, that if you look at psychiatry as a discipline of medicine, just like if you were a family practice doc, you would have those patients that do fairly well but require long-term treatment. Maybe they have high blood pressure or they're diabetic, but they're under good control, but they need to be seen regularly. And then you're going to have some individuals that come in with an acute crisis that you treat and you really do cure them. So a person comes in with a wound or something that's infected. Well, we see people that are going through a situational crisis. Maybe it's turned into a depression. We treat them. They're doing great and they're on their way. And then just like a family practice doc, there are some people with very serious chronic illnesses. And with those individuals, you try to improve the quality of their life. And that's going to vary from person to person. So maybe one person's quality of life is that they just aren't in the hospital all the time. The next person is that they can sustain a marriage or be a good parent. Maybe the next one is they can work in a high-level job, but you just try to improve the quality of their life. And then, like in any other field, there are those individuals that you do the best you can, but they don't do well. They don't respond to treatment, and maybe they even end their life. So we have that full spectrum, just like any other medicine discipline or medical discipline. But I think it's difficult sometimes for people to realize that. And so some people are afraid to see psychiatrists because they don't want to think that they're in that super chronic category. And that's not the case. Other people might not want to see us for what other reason, but we really serve a wide population, a wide range of different individuals. Well, I know you both told me why you like psychiatry. Well, now let's let's take off the gloves a little bit. And what are some aspects of your job that you don't like? Dr. Orland.
I think one of the aspects I don't like is that I'm too busy, and that's maybe an unusual way to look at it. But there's so much demand, and there are many individuals who need things that they're asking of me that I can provide them, but it drains me. So part of it is that mental health is a draining field, and as physicians, we've learned early on to compartmentalize, to find other aspects in our lives to balance, but at times it can become, pretty draining. And I think that's a drawback. I don't know if that's any different than any other field of medicine. In fact, who knows, maybe we're better protected, or at least here we're better protected because we control our schedules. Mm-hmm. I can take a day off if I want to at a time and not pay a price or have to, get somebody to cover or sign off to the chairman that may do something extra for their committee, etc. But I think that would be the biggest drawback I'm thinking of at the moment.
Dr. Sharma?
I would say I don't think I'm alone in this, but I think paperwork is one of the most unappealing parts of my job. There's been an increase in paperwork over the 12 years that I've practiced psychiatry. Paperwork and dealing with insurance companies. And along with that, something that I alluded to earlier, when looking at making decisions for my patients, sometimes if non-clinical considerations get in the way, that also is not appealing. And that again refers to insurance issues and affordability issues. In an ideal world, I wouldn't have to worry about those considerations. And I rarely, if ever, let those considerations outweigh clinical considerations. But sometimes it's a real juggling act to arrive at that kind of a situation.
And it certainly is something that I've noticed. Now, I've been a practicing physician for over 30 years now, and I can tell you over that 30 years, there was a point in the beginning where the doctor was the trusted expert, and if you felt that a patient needed this medication or this treatment, that decision stood as long as you were within certain typical guidelines. And that really has changed, I've seen, over the years, and then really kind of has escalated over the last maybe 2 years, where you prescribe a medication and you get a report back saying, well, you've got to try 4 other medicines before you can prescribe this particular medicine because it costs a little bit more, or whatever. And that can be a very stressful thing for the patient, I think, but it's also stressful for the doctors who are trying to provide the best possible care that they can for their patients. Do you have any last words that you would say as far as either the profession of psychiatry or people that are interested in psychiatry? Any words of wisdom?
I would just add that psychiatry and neurosciences in general remains and will remain one of the most important growth areas in all of medicine, certainly. And in terms of the number of discoveries, we are, oftentimes people say we are, in neurosciences and in psychiatry, we're where internal medicine was 150 years ago, perhaps. We know so very little, but our rate of knowledge is expanding tremendously, almost exponentially. It doesn't look like that from a very, if it doesn't look like that on a day-to-day basis, certainly, because it takes a lot to translate those research findings into actually tools that are useful for people. However, if one takes the long view, humans have been around for 150,000 years. Psychiatry is a very modern discipline. We didn't have most of our medications before 40 years ago, 50 years ago. So when you look at it that way, really everything is exponential.
Yeah, it really does seem like our knowledge of brain science is still very primitive, but so much further ahead than even 5 years ago, where we have a much better understanding how different parts of the brain relate to one another and how neurotransmitters modulate all of those sorts of thoughts and feelings and emotions. Dr. Orland.
And I don't know if it came across with our discussion today, but this is a very fulfilling field. We are given the opportunities and literally the honor to hear patients' narratives, to hear their life, to hear their stories. And that is such a wonderful chance to do that and to give back in humanity, because we have the skills, whether that be psychologically or pharmacologically, to help people improve their lives. And so there are often times I leave the office, especially if I see a new patient who I've been able to change or make a new diagnosis that wasn't previously considered, that I really feel good about my life and where it is and what I'm doing here on Earth. And I don't know what else you can ask for in terms of an experience in life.
And I think sometimes we take for granted the fact that we have this special training and maybe look at life a little bit differently and problem solving a little bit differently. And certainly I think we've all have had the example where even a simple, have you considered this or try that instead of this other thing, has had a profound impact on a person's life. And you're right, very few things or very few disciplines offer that. There are disciplines, and we certainly make a fine living, but there are disciplines where you can make a lot more money. There are disciplines where you may have more prestige. But I think there are a few disciplines, even within medicine, where you really can impact a person's life on such a personal level. And not only are you impacting them, but you're impacting their connections, their spouses, their children, just by that kind of domino effect. Well, I'd like to thank both of you for coming here today, this morning, and talking to me about this important topic. And I do think here at Genesis we have a little different sort of take on things, because we're still, although we're a moderately sized clinic, we still are basically a doctor-run, doctor-controlled clinic, and that allows us to do things like see patients a little bit longer and take care of ourselves too. So thanks to both of you.
Thank you, Dr. Mike.
Thank you for the
Pleasure.
stimulating discussion.
Well, that's our show for today. Make sure you listen next month to Psychiatric Secrets Revealed with Dr. Mike. For more information about me, or if you have an interest in starting your own podcast, please go to my website at www.kunaland.com. That's KUNALAND.com. For more information about Genesis Clinical Services, you can go to that website at www.genesisclinicalservices.com. Remember, Genesis Clinical Services is all one word with no spaces. Lastly, if you'd like to send me an email, you can send me an email to psychiatricsecrets, all one word, at hotmail.com. Don't forget to tell your friends about this great show, and tune in next month.